Welcome to A Shot in the Arm podcast. I'm your host, Ben Plumley, and this is a podcast about innovation and equity in global health. Because, let's face it, without equity, what is the point of innovation? Well, in today's podcast, and we're recording this in person in sunny Sacramento, halfway through the year, just over, we're going to take stock of where we are with global health in what has been an absolutely incredible, crazy, disruptive 6-7 months. And I'm joined by friend of the pod, who hopefully we will be seeing a lot more of in the future. She's a journalist. She's an author. She recently had a piece in the New York Times predicting the agreement that the Senate came to over putting a little bit of money back in for the President's emergency plan for AIDS relief. But I should also say she's something more than that, because we can now refer to her as an expert, as referred to by Christiane Amanpour in a fairly detailed reference in an interview that Christiane held with Zaki Akhmat, the South African HIV leader, on CNN most recently. So, Emily, welcome to A Shot in the Arm podcast. What does it feel to be like an expert?
I mean, one doesn't know until Christiane Amanpour says your name that it's been on your bucket list. We have a responsibility, not necessarily to be the experts always, to be the close listeners and the witnesses and the commentators on what's going on. So it feels crucial. Is the big girl answer, Ben? But there's a small part of me inside that has zero chill that maybe you can get a glimpse of.
Yes, absolutely. And I'm teasing you a little bit, but I thought it was an absolutely appropriate reference, because you've been relentless in covering what is going on primarily in PEPFAR, but also as it relates to the broader health, global health, but also global policy context. And I feel that's really missing. So that's why it's so good that you and I get to talk today. And one of the things I really wanted us to sort of frame this around is, where are we now? What are we getting right in the way that we are articulating the world as it is? And what are we getting wrong? And, as I said, it's broader than HIV, but HIV is really the foundation head for so many reasons into what's going right and going wrong in global health. But at the 38,000-foot level, as I always say, in our aeroplanes going across the Atlantic and back, where do you think we are?
Well, let me start just by acknowledging where we are more globally and then coming in to this, because we are at a moment of polycrises, and we are in a moment of the collapse of humanitarian aid and also of sort of basic humanity, as evidenced by starvation in Gaza, mass starvation in South Sudan, many places where we are seeing the worst of both humans, but also of humanitarian aid failures or prevention of humanitarian aid. So in that bigger context, and with awareness that the metaphor has a literal reality, we are at a moment in the HIV/AIDS field where the dust is settling from a major catastrophic event. That's how it feels very much. That as someone in my LinkedIn feed said at one point, people need to understand the blast radius of what happened in global health. It happened so fast. Many other things happened after it. That we're in many ways ahead of, I think, other sectors, and have a different set of conditions to deal with, because, as I think we'll get to later, the HIV/AIDS response was affected differently than other U.S. humanitarian aid. And so after the shock of the catastrophe that unfolded in January and February, we are now at a moment where the dust is settling, and it's beginning, the landscape is beginning to become a little bit clearer, as are the really dangerous zones and maybe the places to rebuild.
I mean, it's appropriate, I think, that you referred to humanitarian crises, and you mentioned starvation, human-made, but also, climate-related. And it is interesting, isn't it, that you have Gaza on one side, and then you have Sudan underneath. And of course, if you look at what happened to the World Food Programme, it's saying that, it's only able to provide 500 calories a day for the refugees that it feeds in Egypt. And so Egypt's sort of between the two of these. And it really points to the uncertainty and the destabilization from a geopolitical perspective. And it also points to the fact that, this administration isn't really that interested in multilateralism. And again, you can, work your way out of that over a year and a half. But to just suddenly close the door on that leaves a lot of uncertainty, and we politely say disruption. But I wonder whether you feel, and we've seen this with a number of other journalists and commentators in the HIV field speaking, whether you see this leading directly to the kind of mortality and morbidity that perhaps we had thought had gone away from the HIV/AIDS response. In other words, are people losing their lives right now, do you think?
I think some people probably are at this moment. I think but the people, I'm not a clinician, so I won't begin to, but I think what we have with HIV, the best way to understand it is a slow moving tsunami. Again, not to make light of actual recent tsunami risks. I was glad to be reassured that Sacramento is on high ground. As we speak, this is a day or two after the tsunami warning. But, this is a slow-moving tsunami. So I think there is a risk in saying, as one of the narratives that has been unfolding over the past few months is millions of people are going to die, or hundreds of thousands of people are going to die in a short time frame. That epidemiologically, that's not how HIV works. If you were stable and on antiretroviral treatment and had an undetectable viral load and you had an interruption in your treatment, you're not going to develop advanced HIV disease in the next couple of weeks, in most cases. If you're a pregnant woman and you go off your antiretrovirals and you may be healthy, but your viral load goes up and you're transmitting, your risk of transmission to your child is much greater. Your child's risk of illness or death in the first 5 years of life is huge without stable antiretroviral treatment. So there are all different ways that illness and death have become much closer to people living with HIV, and the worst is yet to come.
A clinician from East Africa mentioned to me at the recent Kigali conference in Rwanda, the International AIDS Society Scientific Conference, that they're still seeing many people presenting for treatment with advanced HIV disease.
Yeah.
And so those folks are even more at risk of really serious side effects and adverse events if they then suddenly stop treatment.
Well, let's be clear, because some of this predates what happened in January, with the stop work order and the funding freeze and the demolition of USAID. We had about 30% of patients, I'll have to look it up and we can put it in the show notes, but the rate of advanced HIV disease among people, this is what we'll check, is either presenting for testing or inpatient, has not changed over the last several years, the last many years.
Whoa.
So there has been no advanced HIV disease has been happening in the background. It's been foregrounded by amazing advocacy coalitions and also by clinicians. Chris Beyer of Duke University has done a great job of consistently bringing up that when he goes out to visit Duke partners, whether it's in Brazil, I'm haunted by him coming back and saying, I was in a hospital where the ward was filled with people with advanced HIV disease. And while we need to assign blame, there is a lot of blame, but that is not That is not on Elon Musk. That is not on the Trump administration. That is a reality of the HIV response, which is one of many things that, frankly, was a thorn in our side, an unfinished business prior to this moment of impact.
Or at least it felt like a moment of unfinished business.
Yes.
Whereas in fact, and this is my sort of the wow response, I mean, it points to a very significant failing in testing strategies and encouraging people to come forward for getting access to testing and, the care and treatment
and supporting
support.
people on staying in treatment. Some of this is people initiating treatment, ceasing treatment for whatever reason, and not coming back to care. And we are going to see that happen. We know that that's already happening, that people... So part of what I was doing, and part of what was featured in the Times piece that you mentioned, is I spent 3 weeks in Tanzania and Uganda doing oral histories, which really just means, I asked very few questions. And mostly I sat down with people and I said, what's changed? More than 40 people living with HIV, working on the response, government clinicians, to really get a sense what their lives were like. And the anguish across the board was for people that were working with communities where they were being reached in their communities, or the drugs were coming closer to them at community drug distribution points. And that infrastructure basically disappeared overnight. And with it, the ability to follow up with those clients and make sure that they're coming to clinics where they might or might not feel welcome. And when they don't come to clinics, they then are on a path to developing advanced HIV disease. So which has been an unsolved issue, as I was just saying. And that should be reason enough to take action. I think where we have a risk, Ben, is if we say too soon, you have already killed hundreds of thousands of people with these actions. We have to be able to, to have the world care about people who are terrified and people who might have dropped out of care. We cannot wait for people to care until they're dead, or frankly, until they're starving children.
Well, we've got to speak truth to power. Yeah. Truth means fact. It means evidence. It not means creating a narrative somewhat like J.D. Vance did at in the last election campaign about Springfield, Ohio, with immigrants eating cats and dogs. But we've, as always, Emily, we have dived in right into the detail. And I wanted to step us back a little bit. Sure. I said at the start that I see HIV as a fountainhead, as something that is almost symbolic of the post-Cold War world that we have lived in. And to put it in its geopolitical context, and I don't know why this hasn't been done. I mean, I'm sort of waiting for writers and thinkers to sort of set this out for us. But, it thrives on the UK approach to commercialization, to capitalism. It thrives on this sort of tension between human rights and community responsibilities. It's north, south, east, west. And it seemed to be appealing to our increasingly shortening attention span, thanks to folks like Elon Musk, where we could sort of have seen something like some form of control of HIV happening within our lifetimes. And so when I see people now saying, well, that's it, we've missed it, we're living through an experience where we have snatched defeat from the jaws of victory. I just wonder how you see the contextualization of HIV and why it is so important as a sort of a surrogate marker for what is going on in the way the world thinks about global solidarity.
It's a great question. And one where I want to actually come back, because we've been talking about this, a bit over the past few days of what is it about HIV in the post-Cold War, sort of moment? Like, your contextualization is important. So I'm put a pin in that, because let's hear the capsule history there. I mean, I think the global HIV response that started really with the Global Fund and with PEPFAR, with finally massive infusions of resources for the establishment of antiretroviral treatment programs and a host of other things. But really the centerpiece of those funding streams was adult ambulatory clinical care, right? In places where we didn't have services.
What do you mean by adult ambulatory care?
Well, thanks for asking. In this instance, it's not ambulances. It's I can walk in.
Oh.
I'm ambulatory. I'm on my own two legs. And you're talking about health systems where you have childhood vaccination and you have inpatient services. And you really don't have a health infrastructure for adults to come in and pick up their medicines and leave. Not for HIV, not for hypertension, not for diabetes. It's not a health model in most of the countries where there's huge burdens of HIV in 2002, 2003, when these mechanisms start, but prior to that, right? So, and we're not going to go year by year, lest you're worried. But what you have then in 2003 and 2002 is essentially the beginning of massive experiments in how could aid work that are different from anything that has happened before in any aid sphere. They're different for the Global Fund and they're different for PEPFAR. And those experiments have embedded in them a set of hypotheses, right? A set of design decisions. We are going to, in the case of PEPFAR, we're going to move fast. We're going to prioritize speed over anything else. So we're going to go into non-governmental organizations instead of working with government health systems. We're going to, put the emphasis on getting as many people on treatment as possible through the spaces where we think, and the partners who can do that, even if it's not the government health system, which flies in the face of many arguments that it should be within the government health system, so that, I don't know if the entire funding stream disappears overnight, who could imagine that, that the government could carry on. So there's some hypotheses, or assertions. It's going to be better to go fast. We're going to be right to go fast versus doing it in the government. We're going to be...
Can I challenge you on that a little?
You can
try, yeah. Good luck to me. So what you're describing as an experiment feels like almost the status quo on acid.
No, I'm going to tell you why not, but I'll let you finish your thought.
Thank you.
Okay.
Thank you. Because you have a stream of thinking in overseas development aid that emerges after the Second World War. Partly it is driven by making sure that, the countries that you are aiding, in inverted commas, sit on either the communist or the capitalist side, the US or the Soviet Union side of the equation. But you also have a stream of thinking that suggests that, countries aren't able to do this themselves, and that we, partly out of guilt, partly out of money, partly out of the fact that we have better expertise than they do. That's in air quotes, by the way, because I don't believe that. But that we have to be doing things ourselves because they can't, whoever they are. And in the case of PEPFAR and the Global Fund in the early 2000s, in a sense that I always thought that came to fruition. So challenge me.
I will. So one of the crucial differences is that both PEPFAR and the Global Fund were created, at the behest or as the result of massive demand from impacted communities, which is one of the reasons why and President Bush did a tremendous thing in launching PEPFAR, but he launched PEPFAR because of the activism that brought the price of the drugs down to the place where it was affordable to do so. So I think for sure we have a sort of a colonialist and a post-colonial legacy to talk about in terms of who's setting priorities and who's taking approaches. You're setting approaches, but this was a country and civil society and impacted community demand-driven experiment, right? I mean, nobody was saying we'd prefer it if you went slowly. We'd prefer it if you, could you please actually go into our national health system? People were feeling tremendously abandoned, betrayed, dismayed, heartbroken, outraged by government inaction. Their governments, the Global South, and obviously there's exceptions. We can talk about Brazil. I mean, not everybody was failing. But there was also a real recognition that HIV needed a different approach. And I recently, on this trip back to Uganda, where I spent, I ended up, following clinics there for 18 years for a book that I wrote about PEPFAR. And it's hard to see the terminus of this, which is these systems that don't exist inside the health system. And one of them is the great, tremendous TASO treatment, the AIDS support organization, which is one of the places that we started ART, and it wasn't in government facilities. And I was talking to Alex Coutinho, who's was the ED of TASO at the time that PEPFAR started, and I sort of said, "Oh God, Alex, like, did the U.S. do the wrong thing, by coming in and basically, supporting the establishment of these sort of utopian systems of, peer-led support?" And he said, "Emily, you guys didn't do that. That was our system. We came up with that. It's our system. We wanted it that way, And so I think we must be careful here, because there are things about the HIV response where that experimental phase, let's try things differently, had some really good questions in it. And and that's why HIV is, as you're saying, sort of the fountainhead. And this moment is we have to really be sure we learn everything we can from what happened to date, which we were not doing the best job of. Again, let me be honest, if not the most popular observation, we had not fully taken stock of.
Oh, I completely agree.
That experiment is bubbling away on your Bunsen burner and weird fumes are coming out of it. And, it's time to figure out, what happened. But we've got to really take honest stock of that, because we are now, what got us this far is not going to get us farther.
Well, I think the strange smells, if you like, started in the 2010s. It became, to me, really clear that the experiment that you're describing was becoming less fit for purpose, was becoming constraining. And there were so many occasions in UN meetings, in international conferences, where very well-meaning Northerners, we simplify it by saying they were speaking on behalf of their partners in countries. But there was, I think, a really strong seam of global health thinking that still countries weren't ready to take up the reins. And I think there were two definitive moments where that proved to be the case. Both of them actually this decade. The first was COVID, where,
absolutely,
particularly in Africa, they were, without a shadow of a doubt, left at the back of the line when it came to vaccine equity, when it came to oxygen equity, when it came basically to anything. And there are really good data, really good reports of showing how national AIDS programs, national TB programs came together using the innovations that they developed, particularly with community health workers, to pivot immediately to awareness, prevention, and caring in the context of COVID, ways in which perhaps we in the North failed very significantly on. And I think the other then definitive moment was January and the election of and the assumption, of Donald Trump and the implementation of DOGE. And I heard directors general of national AIDS programs saying to me, "Well, we've done this before with COVID. We'll do this again. We know we are on our own. We know that the model of northern largesse, northern donor funding to help us build responses, those days are over, if they ever existed at all. And we began to see, and we can come back to this in more detail too, that some of the other components of the PEPFAR and Global Fund money of using non-governmental organizations to provide very significant aspects of care outside the national health systems, that those came to a juddering halt.
It was a truth serum moment. Particularly, I'm thinking of what the processes that have been underway, for years, a couple of years prior, were about sustainability planning and trying to begin to have a conversation about what it would mean for countries to take on ownership of their programs but actually, frankly, sort of flailing a little bit, groping maybe for what that means to take on ownership. And again, let's put some of the realities on the table, right? That Congress, which has been the champion for PEPFAR to the point where the acronym, after George Bush, it was not necessarily the president's emergency plan. We always had presidents that acknowledged it. Nobody has embraced it the way that George Bush did. And in fact, it got flat funded essentially in under Obama Biden to this day. Congress, who we must keep happy to keep this program alive, was getting impatient. Wanted answers about what sustainability actually was going to look like, and was there an off-ramp, and the work to provide those answers was happening, but it was happening somewhat slowly, and the specificity in the answers hadn't arrived. And when you see what happened with the total collapse of some elements of HIV programming, you realize that we had a distance to go in some elements, right? By the same token, the extent to which some things have continued really shows that there is / was a sustainability roadmap, and that we maybe hadn't been having, hadn't yet started to have the tough conversations, or that we hadn't. I remember several people, as we were talking about sustainability, saying, essentially, we have to do it or they're going to do it for us. We have to start to think about how this looks differently, what this looks like cost-wise, or they're going to do it for us. And boy, did they ever. And there's perhaps a missed opportunity, though again, I think it's very risky to think about any good behavior that could have averted what happened. Let's not put the responsibility for no one could have prevented the wood chipper from being fired up, right, for you. So fine. But there were things that hadn't happened.
Mm-hmm. Now, there, I absolutely agree with you. And, I come back to some, I think it was Senate, or may have been House of Representatives, congressional testimony that Mark Dybel gave, one of the former ambassadors of PEPFAR, who said, look, we could do this. We need a year and a half. We need a transition plan, phased plan that we work to. What we don't need is a jolt, a sudden collapse. And I think, the administration has to take, historically will, take responsibility for all the distress that has caused. But what in terms of the other features of this experiment were important? And, can I sort of perhaps direct you to what we grandly call the global architecture? You mentioned PEPFAR and the Global Fund. We obviously had UNAIDS in a much smaller role, but as a mouse doing judo with the elephant, helping countries to devise plans and devise strategies that they could then get funding from. Were these models designed and have they been able to adapt and remain relevant?
Yes and no. I mean, I think, the not to be evasive, but I think that again, to be global or broad in a way, and every country is different and contexts are different for many different reasons. I think that what has been done with HIV prevention and treatment is and should be, frankly, a gold standard for how we do both healthcare and pandemic preparedness, global health security work. Because let's remember, HIV was considered a health security threat, and there's something that a social scientist, Andrew Lakoff, calls conceptual mutation, where the pathogen doesn't change, but it goes from, wow, we really have to think about this as a security risk, to, a sort of benign, accepted. And Ebola actually did that at a certain moment before it came roaring back. So let's remember that HIV, the successful HIV programming, was a pandemic, a health security response. It was pandemic preparedness, and some of those pieces are extraordinary, and we need to keep them. We need to look at them, and we need to keep them, and we need to figure out how they fit into country-led and driven models. And we got a little Baroque. We got a little Rococo. We got a little, I would also say that service delivery models approaches the scope of what a particular funding stream pays for. The things aren't necessarily wrong, but there was so much HIV funding that it has ended up paying for and supporting things that really need robust responses from other funding streams, right? And so we have essentials that need to be preserved, and we might have some things around those essentials. We might have, there are sort of things, that have accumulated over the years, ways of doing things, ways of having the money flow, and frankly, even, ways of articulating the future vision. Because let me stop here. Is Mark Dybul the right person to be saying we can do this in 2 or 3 years? And was that helpful, Ben, or did that actually undermine the future?
To me, it was helpful. And let's face it, and not that I'm in any way a relevant stakeholder in this. What I thought was helpful about it was that it captured what I think countries were saying.
But why haven't we heard them say it?
Well, I think they have. I mean, you look at the HIV Leadership Forum. They produced in October last year a roadmap to sustainability. Now, we haven't read it. We don't act on it. And of course, it is very difficult to bite the hand that feeds you, as it were. But I have a fair point, fair cop. I'm interested that as we are talking about this cold cathedral global architecture, we're not talking about one part of it. And I'm intrigued by that. It's the Global Fund. And the Global Fund has done, I think, an absolutely brilliant short-term job of staying out of the firing line in the last few months. But it's got its replenishment coming up, hosted in South Africa, right? Is it, I think?
I don't know.
We'll check that.
We will check.
Yeah. But I do recall there being concerns about South Africa's involvement, given how Trump was interacting with the country. But its role has morphed since 2002, 2003. And perhaps a more similar comparator is in fact Gavi, and Gavi has been much more in the firing line in the last few months and lost significant US funding. But I wonder how you see the Global Fund being ready at this moment. And I've got some feedback and observations I'll share with you, and I do this from a place of deep support and commitment to the Global Fund and the community of practice that the Global Fund has developed.
Well, it's interesting that you say it stayed out of the firing line. I think, this is let's do a little setting of the record straight, right? So this is the one math moment we're going to have, I think, for me, is that we're going to be hearing and talking a lot in the coming months about what Congress does with the President Trump's FY 2026 budget ask, which is for $2.9 billion. And most of the coverage of what that is in terms of a reduction in HIV spending.
Just to be clear, this 2.9 billion is what? It's the everything in the kitchen sink for HIV?
Exactly. So people are saying, okay, 2.9 billion, this is what he wants. This is what he has asked for the U.S. global HIV investment. And the most frequent discussion of this is okay, 2.9 billion in years past, for several years past, we spent 4.8 billion on PEPFAR. So 4.8 is the denominator, right? And then if you do that, this is where we're going to do the little math moment. I did it for us. Okay. So so that's about a 40% cut, right? And you go, 40%. I mean, it's not, USAID went, it was an 87%, and look at the world we're in, where we're, sort of trying to, okay. The total U.S. global health spend for every year since PEPFAR has existed has included additional funding for the Global Fund, to which we are the largest single contributor, with a cap on it of up to a third of the total funds. Okay? And that is 1.7 billion, right? So the total U.S. global health spend this year, this fiscal year, the fiscal year before that, was 6.5 billion. Wasn't 4.9, which is for PEPFAR. And if you use that and that other chunk of money, the overwhelming majority of that is for the Global Fund. So it's off the radar. It's so far off the radar that we're seldom talking about the fact that right now we're going into a budget negotiation where there is no money for the Global Fund specifically allocated for the Global Fund, as there has been in the past, which is 4.7 or 4.8 for a bilateral PEPFAR, 1.7. So, my plea is just use the 6.5 as the denominator when we talk about what that final number is. 6.5 is our multilateral and our bilateral. And with that, we're looking at a 66% cut. So that's just, I'm not, it's maybe stayed off the radar, but maybe too far off the radar.
Too far off the radar.
In terms of being really clear. And it doesn't say, PEPFAR could, or the U.S. global health spend could certainly say, we're going to, we could do it, whatever the 2.9 billion, that could go to the Global Fund. But let's be honest, that's, So, okay. So just end of math lesson. I think that the question I'd love to talk about is where the Global Fund as it's evolved, right, in its present state, and some of the strengths are its country planning mechanisms, its sort of community, its explicit inclusion of community, the way that contra, the aid norms that you were talking about earlier, this has been a country-led planning process. Okay, those are some real strengths. It has funded human rights. It has funded interventions that the U.S., even before Trump, has not always wanted to get its hands on. Okay. Does that mean that it should fill the gap for everything that's left? Or is there another way to think about financing, and particularly thinking about procurement of medications? And Global Fund has paid for a lot of commodities in a lot of settings. And we know that we're looking at commodity stockouts and shortages in the coming months, particularly if you cast the net just a little bit wider than antiretrovirals. We're really looking at frightening things, including the drugs for the illnesses that come with advanced HIV disease. And it's a terrible thing to get meningitis and not have treatment for it, right? So I think, I want to know what you think.
Well, the piece of the equation that we're not talking about is national contributions.
Yeah.
And, we see in many countries in Africa, those that are evolving commercially and socially from lower income countries into middle income country status, we're seeing a massive increase in country-led, country-owned funding that never gets referred to. I mean, there are, wonderful journalists again, not you, reporting in the New York Times about what's going on as a result of these cuts, never referring to the investments that countries have made, both in finance, but in terms of management, in terms of expertise, in terms of capacity. And so I think that is something that will feature into this and will help us, to your earlier point, not be in a situation of, Chicken Little where the sky is falling down. Certainly, at least for those countries that have the economic and social ability to do so. The poorest of the poor, that's a completely different question. I'm interested in what you were saying about the role of Congress in setting the Global Fund's budget, of course. And I remember what happened in the first Trump administration. Trump was constantly proposing to cut the Global Fund or the overall global health budget significantly, and Congress would always come back and do the right thing and mainline that funding. You got to hope that happens again in the next financial year, although given what we've seen with the big beautiful bill act, whatever, the whole analysis of an equation of what America is and how it works financially has changed, because we are basically shifting the public purse to the richest in society. So we will not have the resources to be able to do this. There's one other thing around the Global Fund, and you're absolutely right to talk about its innovation in country-led planning and submissions. Those submissions, of course, went to Geneva, and they went to a global group of experts who decided whether they were adequately evidence-based or not. And then they went to the board, which, of course, is made up of all different sectors, including a very strong partner country set of delegations for approval. And I'm just wondering whether, in fact, the creativity that we're going to see in the next phase of the global AIDS response is not going to be in Geneva or New York or wherever. It's going to be in Addis. It's going to be in different parts of Africa. And I'm really intrigued by what the Africa CDC is doing, what the African Union is doing, the work of Africa CDC just announced around building governance around data, health data. And so this idea of the Global Fund playing a role in procurement, well, that might actually be better placed being done at the continental level, the Pan-African level, certainly for Africa. So those are my thoughts.
No, so I want to be clear. I think the sky is falling. I think it's falling slowly, and there's time to keep it back up in the heavens, as it were. So I think we are not, it is not okay. We are not okay in global health. We're not okay in research, in public health. I mean, the pipeline or the ecosystem in which an effective HIV program happens is clinicians, it's scientists, it's medications, it's trials. The sky is falling. It's falling slowly. Can we prop it up? Maybe. Right. So that, and a couple things come to mind. One is the big, I think you meant to say big bollocksy bill. I'm not sure it's a big, beautiful bill. But, the thing to watch is what happened with the rescissions clawback.
You're right.
And that is significant, not so much because of the amount of money, which is $400 million. And remember, PEPFAR's annual budget is $4.9 billion. And I know there's not going to be a math moment where I do the calculation, but it's teeny weeny percentage. Teeny weeny. Okay. So that's, that the victory there isn't that PEPFAR got its funding back. The victory is that by partisan congressional support materialized to push back against that cut. Right, which is significant because PEPFAR had lost a lot of ground in terms of its bipartisan support for various reasons over the past couple of years. So what that is a great signal going into the budget planning cycle, and what we must have and must see. And again, I think there's always and this has happened with HIV over the decades, is that we often lift up and talk about the exciting potential for country and regional leadership at moments where we're just actually not going to have enough money anymore. And it's and that is where sustainability, where country ownership is widely understood by people in the countries where that phrase is basically being we're out of here. We're packing up our tents.
Which is why these two defining moments of COVID and then January are so important.
They are important, but what I want to say is that we need. Two things need to happen, and they're on different time frames. And one is that the Global Fund, the U.S. global HIV spend must be maintained. So let's do 6.5 billion again, right? Let's aim for that, and let's certainly really aim for that, including the Global Fund spend. And let's be clear that we're not trying to. While we need that this year, we also are not trying to put things back the way that they were before.
And I suppose in your predictive piece in the New York Times, you were showing that kind of bipartisan coming together could happen.
Yeah.
And it did with that teeny weeny 400 million. This would then suggest that you are optimistic that it could come together again in the 26 negotiations for the next financial year.
Yeah, I think. I mean, it's pretty extraordinary that it happened. I like to think that it wasn't only predictive; it was contributive, and it's in a small way. But there were active conversations happening among lawmakers who want to be given a reason to support something that they've been supporting for a long time. And I think that one of the things was a difficult. It's a difficult narrative to keep returning with, but this sort of glass half full versus glass half empty. We are not doing the HIV response in countries a favor by suggesting that it is gone. It is not gone. In the piece we're talking about, there are thousands of clients that were at the time that I was reporting being served by volunteer health workers who are continuing to show up because they don't want to abandon their clients. But what that also tells you is that we didn't lose everything, because countries didn't stop their programs when Elon Musk said USAID won't exist anymore. So I think we need to both say, the sky could fall. We could see just tremendous, preventable, painful death and orphanhood, right? And a return to plague years that we remember. Some of us remember very, very clearly, and others have heard about. But we haven't lost everything yet.
And just to wrap up the conversation of the global piece of the architecture, we can't lay all of this on the United States.
No.
Because you see European donors. I mean, my home country, the United Kingdom, I'm deeply, deeply ashamed at the way, frankly, both Conservative and Labour governments have treated overseas development aid, and particularly treated HIV funding. Our dear friend and co-host Yvette Raphael was looking after a mission of British parliamentarians in South Africa this week. I hope she took them to one side and slapped them hard and said, "Get your acts together." But it's going to be tough. It is going to be tough. And then in that context, you have new funders, particularly from Asia, particularly China, and how they are going to behave. I wanted to shift the conversation to elements of the experiment that also might need some thinking. And I was hoping you might be able to help clarify things in my mind. And it's something that we've spoken about for so many years. We've touched on it today as well. And that's the role of community-based or community-oriented care. And depending on who you talk to, what time of the day, what season of the year, it can mean all sorts of things to all sorts of people. But basically this idea That bringing services closer to the communities that are affected, perhaps having them involved in the provision or at least awareness raising around those cares or monitoring of their effectiveness, can be something that can be both productive from an impact perspective, but also very cost effective. But how do you see the community-based care component of the HIV response evolving?
Well, I thought you were just going to say, how do you see the community-based care response? And in which case I would say, it's, as extremely murkily named, like that we have a real terminology problem. Not to be wonky about it, but I want to separate out from that. And I do think we should start. I think I would argue that this is an important messaging shift potentially, but that we need to make very clear that success in HIV and success in the achievement of ending HIV as a public health threat, or even these goals that are the 95, 95, 95, which is a set of milestones around knowledge of status, treatment, and then virological suppression, can't be achieved without differentiated service delivery. And I know it's not the sexiest phrase, but I do think differentiated service delivery is the public health term of art, if you will, for that encompasses some components that sometimes get lumped into community.
I'm smiling.
Yes, you are.
For members of our subscribers and those who are listening to the podcast, not watching it, I'm smiling because differentiated care started in the Pangea Global AIDS Foundation as a concept.
There you go.
Lovely to see.
We didn't even plan this.
Yeah.
So DSD, if you will, what I saw when, again, and I haven't been back and I know things have changed, but I do think we need to begin to, when I say we, people like me who are not in the countries experiencing these and not in the communities, but know something about where those responses came from, we need to be listening. We need to be in deep alignment with what is actually happening and what sort of, where the ruptures are and where the resilience is. Soapbox over. Differentiated service delivery is multi-month dispensing. It is often dispensing of medications in non-medical settings or non-traditional settings. Pick it up at your barber, pick it up at your church, pick it up on the neighbor's lawn, every 6 months if you're stable. You're in a group, one member of our group goes to get the drugs. It has a peer component often, which is, people who have lived experience like yours will be the ones giving you the meds, or will be the ones if, hey, you came for your refill, but you're not looking so hot. Let's go to the clinic. Well, I'm going to go to the clinic with you because I know, the nurses there aren't always so friendly, right? That's differentiated service delivery. That's often delivered by communities, often delivered by a community-based organization, right? But I think that we want to be very clear. We must preserve differentiated service delivery because it is an evidence-based strategy that makes sure that people know their status, start treatment, and stay on treatment. We need differentiated service delivery. Then I think we also need to look at some of the things that have made the HIV response work and make public health responses work in general. Are where the people who are using the services have the ability to inform everything about them. And so how are they designed? What is in them? What's on the shelves? Who's providing them? Whatever is on the shelf. And here we mentioned Yvette Raphael earlier, but the amazing work of the African Women's Prevention Accountability Board to say, you cannot decide that we don't want a vaginal ring for HIV prevention because you don't like the efficacy result or you don't like that it's user dependent, right? So advocacy to say, I want on the shelf things that I know are important for my community. I need the price to come down. I need the providers to be able to talk about it. I need the messaging, so public health programming designed and monitored by communities is something that the HIV world has done exceptionally well. And I have been working in pandemic preparedness and related fields, and I've spoken to practitioners in these fields. Antimicrobial resistance doesn't have it yet. TB has some of it, right? Pandemic preparedness in the sort of generic sense doesn't have it in the same way, but it's harder to monitor prevention. So we have a mode of creating and then checking the quality of health services, where there is a role where some power has been distributed to people consuming health services, and redistribution of power is at the base of all of this. A little bit of power and more power the activists are always asking for, the advocates. We've got to preserve that, not just for HIV, but for pandemic preparedness. We're not going to remake it with some new movement of PPR advocates.
And here's the problem, because I think when we talk about community-based care or community-oriented services or whatever, in many settings, we're talking about something very, very different, which is going back to the early design of the experiment of moving fast and moving with whoever could get things done to get as many people on treatment as possible. And that is the role of international NGOs in provision of care. And they have played somewhat of a role over the years. They are, apologies for the generalization, but you would see this from the HIV Leadership Forum, viewed as being very expensive, separate from national services. And if we are going to preserve community-based care in the way that you describe, we have to make sure that we disentangle this other component of service provision, which was the international NGO service provider. I can see the face you're pulling. It's as if I've given you a very sharp lime to suck on.
No, it's the fumes from that bubbling experiment. But I know you know the history, so let me say what I'm thinking of, and we'll see if we can disentangle it. Because I am thinking of Felix Mwanza of blessed memory. We lost him too soon. A Zambian with HIV, with a gangbusters career going in IT, who gets his diagnosis and then starts running the Zambian treatment action and literacy campaign,
Yes.
TALC, out of the trunk of his car. And as at one point a health minister said, he's basically just dancing on my head, all day, to secure AIDS treatment access. And I'm thinking of Lydia Mungerera, who, after PEPFAR, after the funds starts coming in Uganda, says, oh my God, we're not meeting the needs of HIV positive pregnant women, and starts Mama's Club. And that's not INGOs. That's actually, and I'm naming a couple of people. Obviously I could go on. Zaki Akhmat, bringing fluconazole into the country, into South Africa, at a point where Pfizer is saying he's going to donate it and Thailand is making it an affordable generic. Those are all instances where people impacted by the public health condition, by the pandemic, by the pathogen in question, are informing decisions about what's paid for, what the policies are, and what the programs are. They're not INGOs. We built INGOs around that work because, frankly, the folks that were doing it were so good at it, and lots of us, okay, I'm not going to, one could say provocatively that
I'm saying something very different. Okay. Because what you're describing seems to me precisely the kind of innovation that comes out of community-oriented care, community-based care, however we describe it. It's the innovation of people on the ground who know their situation and they do things that are right for them. And we need that. That is crucial and needs to apply to broader settings as you describe. I think the thing that is interesting in the experiment going slightly squiffy is that when it came to providing elements of care, whether it's monitoring and evaluation, whether it's procurement, whether it's distribution of tests, whether it's data management, these are things that have gone to, for want of a better word, or set of words, better phrase, the Beltway bandits or the equivalent that have been in country. And if countries are looking at assuming the costs and responsibilities of those components of care, it's crucial that they are, one, brought into the national health system, the national HIV system, not operating separately. And it's crucial equally that they look at the costs associated with that, because salaries that work for NGOs based in Maryland or Virginia are quite different from those that are in Durban or in Lusaka or where have you. And so I think what I'm calling out is a need for us, and you were talking about the importance of communication earlier, of us really clarifying what we mean by the services that we have to keep.
Yep.
And, bits of the experiment that we weren't perhaps thinking fully about, that we weren't, we knew perhaps there was a problem at the back of our mind, but we didn't feel the need to deal with. We have to make sure that those don't come in and dilute the priorities that we need to
No, I think we're
emphasize.
in violent agreement, but I do think that there's still a bit of a language issue, which is that there's community-based care and services, and then there's community accountability work. That's another way to phrase it. And that is not a nice to have. That is not, I think that's what I'm saying, is that when we look at the core components going forward, community-based accountability work that is instrumental in shaping what is offered, in assessing whether it's right, and in suggesting solutions, has to be part of this, because we are potentially looking at really changing the model, at doing integration, at doing various things. We won't know if the sky is falling if we don't have a community accountability piece. And this is a conflation that is persistent in this conflation of community care and then community engagement, right, with community accountability, because community accountability can get really uncomfortable. So, it's people challenging authority. That's why if you look at the international health regulations for pandemic preparedness and response, there is no clarity on how people should be engaged in decision making. But by God, we need to go and make sure that everybody understands the public health messages to carry forward. So it's the difference from me, saying, here's how I'd like you to talk about Mpox in your community because you're a trusted leader, and you being at the table with me and saying, your vaccines are not getting taken in this province, and I can tell you why. It's because the nurses are all, hugely stigmatizing towards people with sexually acquired infections or whatever. So I think we need to value and specify accountability work. It's not care work in the same way, but it's crucial. And then we need to look at uncomfortable truth alert, right? That many groups that could do accountability work, many individuals, were highly dependent on PEPFAR resources for their income, for their ability to pay rent, to pay their kids' school fees, to stay safe, all for service delivery.
Here is the issue, and I agree completely.
Oh, thank God.
And it's where I think we have to look back at our history to make sure that we continue to defend community accountability, because much of what you're describing is what any civil society would do, protected by rules, protected by democratic norms and institutions. You want your citizens, frontline receivers, observers of services, to be able to feed back to you. That works, of course, in those settings where we have an emerging democratization. That's not the trend of the world at the moment.
Sadly not.
But, and you have seen this in places like Uganda, which you know very well, there have been carve-outs in HIV that, notwithstanding perhaps a lack of lifting of restrictions, there have nonetheless been a sense of willingness by authorities to have that kind of community accountability in the context of HIV. Yeah. And I think that's the thing that we really have to go hell for leather to try and protect.
Well, to protect and to expand. I mean, I think, it is uncomfortable. It can be inconvenient when you have community challenging you. And it, certainly was in COVID as well. You did have community accountability work. And the architects of the pandemic preparedness response, architecture, the architects of the architecture, Ben, have done a great job of sort of throwing up their hands and saying, we can't figure out who the impacted communities are. They're different every time. So there's which is actually, it's convenient because then you don't have those uncomfortable conversations. So, and yet the future of any outbreak defense, any outbreak response depends on something that HIV actors know how to implement. And so we discard it at our peril. For HIV, but for broader issues. So that's a drum I like to beat. One of the other things that I've been doing the past few months that I did both in these interviews, but then I've done sort of significant work with about 10 countries with the groups that, as we know, euphemistically called key populations. All right, so men who have sex with men, transgender women, sex workers, who were disproportionately impacted by the cessation of most of their prevention services, all of their prevention services under the waiver that has allowed other PEPFAR services to continue. Overwhelmingly, what people, and the questions were, what did you have on January 19th, 2025? Where were you at? What have you lost? What do you want going forward? And with a lot of consistency, we would like to be able to go to the general population health services with everybody else and not get abused. We don't want, we need a few drop-in centers. We need safe houses. We need we need some infrastructure for people to be able to survive violence and stigma and extreme harassment. We're going to need that safety and security, those spaces. But for our routine medical care, wow, we would just like to not be in a situation where it can vanish overnight because a funder pulled out. And that's what happens if you have freestanding KP clinics or KP centers. We need some of them. Nobody's saying I don't want any of them back. So this can't be quoted out of context, but there's a real sense we would just like to go to the clinic and not be mocked, hated, made to go sit in a corner for, people who have, so we can all judge them. We'd just like to go get our care because we'd feel safer. And also, so people said that, and also, wow, we would love it if there was regional manufacturing of antiretrovirals. So let us be really clear, and this is, I think, maybe a way to sort of bring some of these threads together, that as was the case when these experiments started, and as Dr. Coutinho reminded me when I said, oh, did we build this great? No, Emily, you didn't build anything. Fair enough. The ideas for what's going to come next are not coming from here. They're not, and they are already, and they always have been in play in communities. And the systems for elevating them and then implementing them have waxed and waned over the years. And I think part of what you're seeing with the INGO piece, with the International Implementing Partner, I hear that and I think, yeah, we did some great listening. And then, as well-meaning white people or well-meaning, people from wealthy nations tend to do, you go, okay, that's a great idea. Thanks. I'm going to figure out how to make it happen. And I think we have to remove that role, because frankly, we don't have it.
Yeah.
We don't have the money. We don't have, and just go, oh yeah, I remember. The countries and the communities know what needs to happen, and they probably have, the roadmap, and what would it mean to create funding mechanisms that can finance those roadmaps and not leave anyone behind. And then we are going to have special services for special populations or special approaches for special populations, at the same time that we need to understand what a country-led provision of service model really truly looks like.
Absolutely. So, I mean, we've extended and gone well over our time, as I didn't doubt that we would. We have not covered HIV prevention in any meaningful part. And I propose that we come back to that in a separate podcast conversation if you're up for it.
Completely, Ben.
Because it's an area where, frankly, despite everything that we've done, we cannot claim success. And there may be limited examples from some countries, some communities, but with new technologies, with new approaches, we have got to get our head around preventing and making sure that we can truly make HIV a historic epidemic, not a historic epidemic.
That's right. And not have a conceptual mutation, but actually a conceptual shift that's based in. We should come back to it. We've touched on a lot of the important things today. I think first and foremost, which is maybe where we can pick up, is we've got to be honest about what we have and haven't achieved to date with pre-exposure prophylaxis so that we can figure out what the new tools are.
Look, we're getting into it right away. Yeah. I promise you, probably by the joys of virtual connection, we'll have this conversation. Emily, thank you so much for being here with us in person and giving us a chance to have a fairly direct conversation about the challenges our dear HIV response faces at the moment.
Thank you so much, Ben. And I know I'm not alone. I feel responsibility to your enormous fan base and also listeners that may have started to listen to your new essential podcast, Colon Meat Cancer, to say, how you doing?
Well, I'm ready for a lie down. I don't know about you.
Well, we love you. We're here for you. We appreciate the wisdom. I appreciate the wisdom that connects the personal and the political and the public health in so many beautiful ways.
Oh, thank you so much. And as I say, I'm hoping towards the end of the summer, early fall, we'll be able to make some more interesting, exciting announcements about where A Shot in the Arm podcast is going with you involved.
Stay tuned.
So stay tuned.
Exactly.
Well, that's it for this episode. Thank you to journalist, author, and expert Emily Bass. Thanks also to Erica Spera, our director and producer from A Shot in the Arm Media. And finally, a big thanks to you. Now, you know that you can subscribe and like wherever you download your audio podcasts, but we're also hoping that you'll get a chance to visit us on our YouTube channel, www.youtube.com/@ShotArmPodcast. Subscribe, like, and hit that notification button so that you can get the heads up when we release that terrific conversation that is going to happen around HIV prevention in all its glory, including pre-exposure prophylaxis. So with that, have a great week and a safe week, everyone.